I welcome you all on behalf of Indian Society of Pediatric and Adolescent Endocrinology, and I would like to tell you about this theme of ISPAE ACES. This is our 15th series, and it is based on adrenal disorders. We have been doing this since Madam Dr. Shaila Bhattacharya became the president, and she's a professor in pediatrics and at JMMC Davangere. And she's also a pediatric and adolescent endocrinologist at Shivajyoti Clinic and Manipal Hospital, Bangalore. She is convener of Pediatric Endocrinology Fellowship and author in pediatric endocrine textbooks. She has published original articles in various national and international journals. She is presently perhaps traveling, and she won't be there to continue here. And I would like to introduce our first presenter, Dr. Jyotsna. She's a clinical fellow in pediatric and adolescent endocrinology at Manipal Hospitals. She will be presenting a case, and her mentor will be Dr. Riaz. He's an associate professor in pediatrics and in charge of the pediatric endocrine department in Government Medical College, Trivandrum. He is an executive board member of Central IIP, and he is also a co-author in ISPAE National Guidelines of Congenital Hypothyroidism. He is a member of State Technical Committee on Rare Diseases and has been a speaker in various national and international conferences. And as a part of technical committee, he has established comprehensive care clinics for children in type 1 diabetes in various parts of states of Kerala. So I would like to invite both the mentor and the presenter. And Jyotsna, you can start your case.
Hari, good evening. Yeah, you can hear me, right? Hari, you can hear me?
Yes, ma'am.
Yeah. I'm sorry, I'm traveling. A warm welcome from ISPAE. We have Dr. Jyotsna here from Bangalore, and Dr. Riaz, as Dr. Hari has mentioned, from Kerala. I also welcome Dr. Sri Nagesh, who has joined us from Hyderabad, who is a MD Pediatrics and Pediatric Endocrinologist, Adult Endocrinologist and Pediatric Endocrinology, both he does, because he was MD Pediatrics and then DM Endo. A warm welcome to Dr. Sri Nagesh, and I think we can start. As I'm traveling, my video will be off, but I will be with you all. Thank you, Hari.
Thank you, ma'am.
Thank you, madam. Thank you, Dr. Hari. So today we are having a very interesting case about adrenal insufficiency. So all of us are familiar with cases of congenital adrenal hyperplasia, where babies may come crashing to our ER in the first or in the second week or third week of life. So the question which Jyotsna is asking us today is all adrenal insufficiency is only CAH? So she is going to present to you a very interesting case. Let us hear the case from her. Over to Jyotsna.
Thank you, sir. Thank you, Shaila ma'am. Thank you, Hari sir. Thank you, Riaz sir. Now I will be sharing my slides now. Good evening to everyone. On the outset, I would like to thank Dr. Shaila ma'am for guiding me, and also Dr. Riaz for helping me with this presentation. Okay, I'll be today presenting on a case of adrenal insufficiency. So the case is that of a 13-and-a-half-year-old adolescent boy who was treated as a case of salt wasting CAH since 45 days of life. And he presented with history of generalized hyperpigmentation of skin. He was already taking oral hydrocortisone and fluorocortisone with poor compliance. So a brief history of previous history. Antenatal history, there was no history of any miscarriages, drug intake, or maternal virilization in the mother. The birth history, he was born to third-degree consanguineous marriage by LSCS. His his postnatal history was uneventful, and immediate postnatal history was uneventful. He was discharged on day 4 of life, and his development was also normal. In his family history, there was no history of any infertility. And there was a history of two of his father's brothers dying. And the father started shaving at 18 years and the mother had her menarche at 12 years. In the past history, starting from the beginning, so after the first week of life, child had history of poor feeding, difficulty in gaining weight, and a history of increasing skin pigmentation. And he presented at 45 days of life in a peripheral hospital with complaints of fever, vomiting, lethargy, and he required hospitalization for 20 days. So on examination, he had severe dehydration, in shock, and the BP was not recordable. He had weight loss, diffuse hyperpigmentation, and his genitalia were normal. And he was treated with IV fluids, antibiotics, and IV steroids. His investigation showed hyperkalemia, hyponatremia, and 17 OHP levels were also in view of the clinical picture. It was measured and it was slightly elevated. It was 4.1 nanograms per ml. He was diagnosed as the case of CAH and he started on hydrocortisone and fludrocortisone. So he came to us first at 13.5 years of age. He was already taking hydrocortisone at this dose along with fludrocortisone. On examination, his vitals were stable, his BP was normal, and his anthropometry showed that his height was at the 25th centile and he was short for the parent. On examination, he had hyperpigmentation, his SMR was prepubertal, and his systemic examination was normal. The 17 OHP levels that was measured were also normal. So was it CAH or was there another cause for the adrenal insufficiency? Let's see. So the steroids were tapered over 2 months and stopped for 1 week. And the parents were counseled regarding the warning signs for the adrenal crisis and he was monitored closely. And the emergency card was also given to them and the ACTH stimulation test was done. So the ACTH stimulation test done with 250 micrograms of synactin given IV, it showed that the basal cortisol level was low and ACTH was elevated and the stimulated as well as the baseline 17 OHP levels were not elevated. So this was the case of primary adrenal insufficiency with normal 17 OHP levels. And I was continued on treatment. We had increased the dose of hydrocortisone and fludrocortisone. He was continued at 100 mics per day. And the parents were advised to do a genetic testing to know the cause for the primary adrenal insufficiency, but he was lost to follow up. So this is a slide to show why we say that this is not a case of 17 OHP, because in salt wasting and simple virilizing CAH, the baseline 17 OHP must be more than 20 nanograms per ml. And after ACTH stimulation, they should show another elevation. But in this case, probably because of stress, there was only a slight elevation. It was only 4.1 at 45 days of life, and he came with adrenal crisis. So going to the time when he presented to us after being lost for follow-up, he was 16 years of age. And now the concerns were that he was not attaining secondary sexual characters as compared with peers. He was taking hydrocortisone and fludrocortisone, though the compliance was slightly on the poorer side. And his SMR was still pubertal. And in the growth chart, we can see that the height was now below the 25th centile. So in the investigations, the electrolytes were normal, 17 OHP was normal, the thyroid function tests were normal, and the basal hormones that we had tested for LH, FSH, they were prepubertal. Testosterone was also in the prepubertal level. The bone age X-ray showed that it was delayed by 4 years. So we planned for a GnRH stimulation test with leuprolide, and this revealed that his LH, FSH did not rise. So LH did not rise at 60 minutes and testosterone was also low. Both basal testosterone as well as 24 hours testosterone were low. So now the difference, we need to remember that the history of puberty, father shaving started only at around 18 years. So was this a case of constitutional delay in puberty or hypogonadotropic hypogonadism? So next we proceeded with doing the inhibin B and AMH levels for this child. So for knowing about inhibin B, we have to compare the levels which are found in hypogonadotropic hypogonadism and constitutional delay of growth in puberty. It shows that this is fitting into the hypo category, where the inhibin is less than 35 picograms per ml. So it was 16.6. And why we take inhibin as a more sensitive marker is that in both hypo and constitutional delay in growth and puberty, the AMH and inhibin AMH levels can overlap. So inhibin, taking the inhibin as a more sensitive marker, we arrive at a diagnosis of hypogonadotropic hypogonadism. So this time the parents, they have done a genetic testing for this child, and it came positive for DAX1 mutation. There was a missense mutation in the exon 1 where there was a substitution of leucine by prolin. And this is found in a condition called as adrenal hypoplasia congenita, which is of X-linked inheritance. So what is the DAX1 factor? It is a nuclear receptor that is involved in the sexual differentiation right from the embryonic period. It is required for the normal adrenal development and also for the development of gonads. So in these children, although the fetal adrenals are normal, the definitive or the adult adrenals are not formed, leading to adrenal insufficiency. Also, the cause for hypogonadotropic hypogonadism is that the gonadotropes which produce LH and FSH, they are not able to produce because of the DAX1 mutation. This leads to the hypogonadotropic hypogonadism. So as adrenals, the anterior pituitary as well as gonads are affected. So the final diagnosis is that it is a case of primary adrenal insufficiency and hypogonadotropic hypogonadism resulting due to the DAX1 mutation. So child was started on testosterone injections, first at a lower dose of 100 mg IM once in every 4 weeks for 3 months. The dose was gradually increased every 6 months up to 250 mg IM every 3 weeks. So after starting testosterone, the child started acquiring secondary sexual characters. So currently the child is 21 years old under the follow-up of adult endocrinologist. He came to us recently and his vitals were stable, his BP was also normal, and he continues to be on hydrocortisone and fludrocortisone, and he is right now on testosterone depot injections, testosterone undeconate. He's taking 1 gram every 75 days. So brief discussion on adrenal insufficiency. It can either be primary or secondary. Primary occurs in the setting of adrenal disease, and mineralocorticoid deficiency invariably occurs. It can be either inherited or acquired. Whereas in central or secondary adrenal insufficiency, it occurs due to a deficiency of ACTH, and it can occur due to lesions at the level of hypothalamus pituitary. And usually in these cases, the renin-angiotensin system is intact and there is only deficiency of glucocorticoid. The clinical features usually in primary adrenal insufficiency, there will be hyperpigmentation, and that is due to the increased alpha MSH levels and beta lipoprotein levels. Glucocorticoid deficiency leads to hypoglycemia, vomiting, fatigue, and mineralocorticoid deficiency can cause hyperkalemia, hyponatremia, acidosis, salt craving, etc. Androgen deficiency can lead to decreased facial body hair, that is pubic hair, axillary hair, etc. So for the diagnosis, the base investigations that we do in the initial stages include the 8 AM cortisol, ACTH, serum electrolytes, plasma renin activity, and aldosterone. The synactin stimulation test is done by the IV administration of synactin. And interpretation is that more than cortisol rising more than 18 microgram per deciliter, it rules out adrenal insufficiency. After that is a 30-minute and 60-minute sample. So in primary adrenal insufficiency, we usually expect the ACTH to be high and the cortisol to be low. In cases of adrenal insufficiency where there is both glucocorticoid as well as mineralocorticoid deficiency, it can be caused due to isolated adrenalitis due to auto antibodies, or it can also occur in cases like APS1 and APS2, in which the AIRE gene is also involved. And in other cases, such as in this child, we need a genetic testing to prove the cause, and it can also occur in syndromic forms and other metabolic disorders. Acquired causes include adrenal hemorrhage and post-infection like TB, etc. And the other ancillary investigations include looking for other hormone deficiencies in case of a suspected central cause, ultrasound abdomen, CT abdomen, and MRI brain in cases of central causes, as well as in adrenoleukodystrophy. So management involves managing the adrenal crisis, chronic adrenal insufficiency, and stress dosing. And all the patients with AI should be given an emergency card that contains the information about the dose of hydrocortisone during crisis and collection of the critical sample. So in adrenal crisis, we need to provide IV hydrocort at a dose of 100 micrograms per meter square, and fluid resuscitation should be done, including correction of hypoglycemia and volume replacement, followed by maintenance dose of hydrocortisone. In chronic AI, the aim is to maintain water and electrolyte balance to achieve a normal physical growth and puberty, general well-being, and sexual function. It is usually given at a dose of 7 to 12 mg per meter square hydrocortisone in 3 divided doses, with the largest dose being given in the morning and the last dose given 4 to 5 hours before the bedtime. And fludrocortisone is given between the dose irrespective of the weight, that is at 100 micrograms per day. And in infancy, it is also essential to provide oral sodium chloride supplementation. Stress dosing is given during fever, gastroenteritis, and other illnesses, where the dose has to be the regular dose has to be doubled or tripled for 2 to 3 days until the child recovers. During this period, adequate hydration and electrolyte containing fluids must be given. If they are unable to tolerate, IM hydrocortisone can also be given. And during surgery or any major procedure, we have to give stress doses. For major surgery, we give 100 mg per meter square of hydrocortisone, followed by maintenance dose in 4 divided doses. So the take-home message from this presentation would be that not all cases of adrenal insufficiency are congenital adrenal hyperplasia, and the 17 OHP levels must be interpreted carefully age-wise and taking into account the clinical presentation of the child. So the non-CH causes of adrenal insufficiency, we need to look out for the other associations, and genetic testing, of course, acts as a valuable tool for confirming the diagnosis. These are my references. Thank you, one and all.
Thank you, Josna. We can stop share, I think. Okay.
Yes, sir.
So it was a, as I told in the beginning, it was a very interesting case and well presented by Josna. As pediatricians, we should all be aware of such conditions, because these are life-threatening conditions where the child will come with different presentations. Because CAH even, sometimes the male CAH, we are going to miss at the time of birth because the genitalia will be normal. So the only way to identify the male CAH is to do a screening for congenital adrenal hyperplasia at the time of birth. Otherwise, the baby may come to us for in a state of shock, or the child may become sick at home. And like that, we should also emphasize on the examination of the genitalia at the time of birth. Even we now also we see cases coming to us, virilized female who were passed on as undescended testes, male with undescended testes at the time of birth. So the clue in a child or in a baby that is 46XX CAH, that is virilized female, if it is a CAH, there will be a hypospadiasis. So if we are seeing a case with hypospadiasis and gonads are not palpable, always remember that could be a case of virilized female CAH. So that baby should not leave the hospital without an evaluation for CAH if we are not doing a universal screening for CAH. That is one thing. Another thing is, we all of us see such cases like what Josna presented, because when the baby comes at a very young age, like 2 weeks, 3 weeks, with the features suggestive of adrenal crisis, like hyponatremia, hyperkalemia, the child is having failure to thrive, shock. If it's a male baby, all of us make a presumed diagnosis of CAH. And in that cases, whenever we get a borderline 17 OHP, we should go a little forward and evaluate for other causes of adrenal insufficiency. Because these subset of patients who are having DAX1 mutation, they may present at different ages. Maybe a large percentage of them will be presenting in the initial weeks of life with the adrenal crisis. And later also, in the childhood also, these children can come with some features of adrenal insufficiency. And later, at the time of puberty or in the peripubertal age, they will come with features of delayed puberty. So there are various types of presentations. And the reason for hypogonadotropic hypogonadism in DAX1 mutation is mainly because in these cases, there will be a decreased secretion of GnRH from the hypothalamus, as well as the sensitivity of the pituitary to GnRH is decreased, as well as LHFSA secretion from the pituitary is also less. And also we should remember DAX1 gene is important in the development of the testis also. So this child, I think, gives us a reason to think beyond CAH in case of adrenal insufficiency. And I think there are some questions. Okay, one question is ACTH sampling is difficult. How quickly it is processed in the lab? It is very important because ACTH, we know by the time the blood reaches the lab, the ACTH is a very unstable hormone and we get very low values and we may miss a proper diagnosis. So always remember ACTH should be transported with ice, like we transport for ABG. And for ACTH, we take the sample in an EDTA bottle. So that should be remembered. And if the lab is not doing it immediately, ask them to properly store it. So that is very important. And another question in the chat box is regarding the genetic testing. So whenever you see a case of adrenal insufficiency, which are having different presentations, like Josna may have said about one case like AAA syndrome or Algrove syndrome, where we have other features like you have other than the adrenal insufficiency, the child can have achalasia cardia as well as a decreased tear production, that is alacremia. So when we are seeing some odd findings, we should go for a genetic testing and do a proper evaluation. And in all cases where we are getting a borderline 17-OHP in a male, we are just stamping the child as a male CAH and we are getting only a borderline 17-OHP. Or even with the adrenal, even with the ACTH stimulation test, there is no increase in 17-OHP. We may have to go for genetic testing for making a proper diagnosis, because making a diagnosis has major implications in the management of the child. In this child whom Josna has presented, the managing only the adrenal insufficiency is not enough. We have to follow up this child through his puberty and help him to go through those milestones. So that is how this case is important. And I think we will be discussing more about adrenal insufficiency because we are having an expert talk on the topic. And I think it's time for the talk. And I would invite comments from Shaila Madam as well as Dr. Divya, Dr. Hari and all the panelists here, if you want to add something.
Thank you, Dr. Riaz. Actually, he was born somewhere else, as Dr. Jyotsna said. Came to me only at around 13 years of age. At that time, the tongue was completely very hyperpigmented, like how she showed in the picture. So, and as a follow-up, when we did 17-OHP, it was low. And the dose was also very low. So, we thought initially compliance, followed for some time, but somehow when we dug the history and what was done, I was not satisfied. So that's how we thought he was already a big boy. There won't be major crisis. We advised them and then we started working up of the case. But later on, only after 16 years, when they came for delayed puberty, then all these DAX mutations and all evolved. As you rightly said, when something is not right, if facilities are available, we should go for genetic test. Not everybody can afford it. Only we will have to put 1+1 like hypo with, even if we don't have a genetic test, if we have adrenal insufficiency and hypo, you should think of DAX. Like how you said, if we have all the symptoms of Algrov's, then we should think, and if again facility is available, we can go for genetic test. So we are still in both the generation of clinical diagnosis and also genetic diagnosis. Thank you. Well discussed case by you and Dr. Jyotsna. Any comments, Dr. Nagesh?
A very good, very well worked up case, ma'am, and she has made my job very easy because she has discussed.
I know. I thought so. She
About,
has discussed a little bit of
majorly, so that I can focus on the important things in my talk, and I really appreciate the fact that you got a very good diagnosis out of a DAX1 case.
Yes. Thank you. Thank you.
Thank you, sir.
Dr. Riaz, you can introduce Dr. Nagesh.
Okay. So we are going to the next. We are going to the next session in our meeting today. And for that, we have a renowned endocrinologist, Dr. Nagesh. He is well known in the field of endocrinology and pediatric endocrinology. And he is a fellow of ISPAE ACES, ISPAD, and in different years. And also he had to his account a lot of awards like Anil R. Sheth Award for Best Paper in ESICON in 2017. And he has written 25 peer-reviewed publications as well as textbook chapters in various books. And I think an endocrinologist with a pediatrics background, he will be the best person to discuss adrenal insufficiency in children. Over to you, sir, for your talk.
Thank you, Dr. Riaz. And at the outset, I'd like to thank Shaila ma'am for inviting me to this wonderful meeting. The next, I hope my screen is visible. For the next 20 to 25 minutes, I would like to discuss about adrenal insufficiency in children with an emphasis on the causes, consequences, and care of children. This is how my case is going to be. I don't want to make it very didactic, so I'll give you a very brief overview of adrenal insufficiency. Go ahead with a case scenario, and through the case scenario, discuss the causes, the clinical features and consequences, evaluate and then treat. And towards the end, I'm also going to give you a very interesting case scenario, probably one of the most interesting cases in adrenal insufficiency you'll ever encounter. Basically, to define adrenal insufficiency, it actually means the inability of the adrenal cortex to produce sufficient amount of glucocorticoids and or mineralocorticoids. It might be because of a defect at the level of the adrenal, or it can be a defect at the level of the pituitary gland. And contrary to what we generally see in endocrinology, we have very few life-threatening conditions in endocrinology. Probably diabetic ketoacidosis, hypoglycemia, hyperosmolar, ketotic coma, some of these. Adrenal insufficiency is again another potentially life-threatening condition in endocrine disorders. This is how it is spread out. You have a primary hypoadrenocortisolism where the adrenal gland is damaged, which is manifest by a decreased level of cortisol, a decreased production of aldosterone, as well as the sex steroids. A secondary hypoadrenalism where the pituitary gland stops producing ACTH. So majorly it is here the glucocorticoid axis which is affected, the mineralocorticoid axis to a lesser extent, because a lot of the mineralocorticoid axis is dependent on the renin-angiotensin system rather than on ACTH. Only 25% of it is actually under the control of ACTH. And we do have a significant amount of fall in the sex steroids. But for practical purposes in this conference, I'm going to discuss majorly about primary adrenal cortisolism. And to go ahead with the case scenario, this is a real case which I've seen just a couple of months ago. A 5-year-old who was referred for evaluation of short stature, a known case of adrenal insufficiency who was actually detected on the first day of life, presented in shock with severe hyperpigmentation with a low birth weight and a possible suspicion of intrauterine growth retardation. did not have any genital ambiguity. On evaluation, she had an ACTH of almost 3,900 picograms per ml, a cortisol which was very low, undetectable, less than 0.5 milligrams per deciliter, high potassium, low sodium, and like as was pointed out by the previous speaker, 17-OHP is not always high, especially in cases of pure adrenal insufficiency. This 17-hydroxyprogesterone, we cannot actually say that it is very high given the very high level of ACTH we saw in this case. She was then started on IV fluids and hydrocortisone infusion, ventilated for almost a week. She recovered, started gaining consciousness after 3 days on ventilator, and then she was shifted on to CPAP. Subsequently started on oral hydrocortisone and fludrocortisone. And at the age of 5 years, she's right now on hydrocortisone 2.5 mg twice daily and Fluricort of 1 tablet and 1.5 tablets on alternate days. She is now referred for evaluation of short stature. Presented with a height of 99 centimeters, which is less than the third centile at the age of 5 years, height age of 3.5 years, and a height standard deviation score of -2.8, a weight of 14.6 kilos, which is less than the third centile, and a weight age of 3 years, a mid-parental height of 164 centimeters without any hyperpigmentation or ambiguity. But she did have mid-facial hypoplasia, low set posteriorly rotated ears, hyperteliorism, and did not have any goiter. This brings us to the basic evaluation of a case of adrenal insufficiency who's brought to us in the OP. We have a lot of tables for adrenal insufficiency evaluation. Many textbooks have given us many methods of looking at the etiology. For convenience sake, I usually divide them into 5 main categories. The first one is the congenital syndromes. The second category into which I divide them is autoimmune disorders. The third is inflammatory disorders. The fourth are disorders of ACTH resistance. And the fifth and the commonest cause is congenital adrenal hyperplasia, which constitutes anywhere from 70 to 87% of all causes of adrenal insufficiency. But for discussion's sake, to a great extent, I'm going to restrict myself to pure adrenal insufficiency today because we've got another very eminent speaker who is going to speak subsequently about adrenal hyperplasia. And this is one interesting article which was published recently, which has actually looked at primary adrenal insufficiency from a genetic perspective. The most common genetic causes we see are the first case, which was already discussed earlier, a DAX1 mutation. Second one is the steroidogenic factor 1 related, which is a bit downstream of the DAX1. Common syndromes like image and image-like syndromes. The Mirage syndrome, which is quite rarely seen, and very rarely you see other syndromes like the WNT4 related circle syndrome. Rarely genetic causes can be idiopathic, especially in children who present as early as the child who presented now on day 1 of life. But we cannot really point out the genetics in almost 100% of the cases, and 10% of them do remain idiopathic or unknown. Classically, if you look at the features of these various syndromes, Mirage is an acronym of myelodysplasia, infection, growth restriction, genital phenotypes ranging from 46XY sex reversal, and enteropathy. Image syndrome is very commonly seen as an association of adrenal insufficiency with growth failure, like was typically seen in our case. Intrauterine growth retardation, metaphyseal dysplasia, not always seen, adrenal hyperplasia congenita, and genital anomalies, especially in the male child. And the gene implicated is CDKN1C. Adrenal hyperplasia congenita, which was what was seen in the present case, where you present with a salt-losing crisis, and a case which is being increasingly recognized, which is known to present with a very severe phenotype, the side chain cleavage enzyme involvement, which presents with as a CYP11A1 gene, with a salt-losing crisis and delayed puberty. These are the common genetic causes of adrenal insufficiency. We have a lot more genetic causes, which number only a few cases for each of these genetic conditions. Autoimmune cases are also seen very commonly. They can either be type 1 APS, autoimmune polyglandular syndrome type 1, or autoimmune polyglandular syndrome type 2. APS1 presents with what is known as an episode syndrome, autoimmune polyendocrinopathy, candidiasis, and ectodermal dystrophy. And the one which is more commonly seen by us in clinical practice adrenal insufficiency, thyroiditis, and type 1 diabetes mellitus. In fact, for making a definitive diagnosis of APS2, primary adrenal insufficiency has to be involved in the disorder. Without adrenal insufficiency, you can't make a diagnosis of APS2. It has to be APS3 or APS4. This is considered a disease-defining condition. Inflammatory disorders are very commonly seen in the Indian setup, especially in the adults, less common in the children. Tuberculosis is one of the commonest causes of adrenal insufficiency, both in children as well as adults. Rarer causes like fungal infections and cytomegalovirus. And if you got experience with evaluating children in the setting of HIV, Mycobacterium avium intracellular associated with an HIV infection is quite often reported as a cause of inflammatory adrenal insufficiency or Addison's disease. Other rare causes, which are basically a kind of ACTH resistance, a familiar glucocorticoid deficiency, which is seen in the MC2R gene. This condition again presents with an adrenal crisis early on in life, severe hyperpigmentation, hypogonadism in the male, delayed puberty in the female, which is very similar to what is seen with a side chain cleavage enzyme defect of adrenal insufficiency. But it is a more milder variant, and AAA syndrome, which was mentioned by the previous speaker, which presents with a combination of ACTH resistant cortisol deficiency, achalasia, and alacrimia, which contributes to the AAA. And often a fourth A is also involved in this, which is autonomic neuropathy. These are the common clinical features you would actually see. If somebody presents very early in life, they present with an adrenal crisis, as was seen in our patient, severe weakness, hypotension, severe hyponatremia and hyperkalemia, hypoglycemic episodes, in fact, even presenting with seizures, abdominal pain, nausea, and vomiting can present in very young children, leads to reduced consciousness, delirium, and loss of consciousness. Slightly older children can present with fatigue, easy tiredness, inactivity in school, hyperpigmentation, especially in the sun-exposed areas, the palmar creases, the breast area, the areola of the breast, mucosal membrane, especially the buccal and the gingival hyperpigmentation. Very often it's gingival hyperpigmentation, which is missed in a lot of cases of adrenal insufficiency. And if properly looked for, this can be a very good pointer. The dorsum of the tongue is another site which is commonly missed in evaluation. Presents with weight loss, low blood pressure, and failure to thrive in children. Uncommon presentation is with hypoglycemia, because hypoglycemia usually presents in an infant, not in a slightly older child. And further evaluation of our child, because she's already on treatment with hydrocortisone and fludrocortisone, and ACTH evaluation is not recommended. She had a workup of IGF-1, and the IGF-1 was 80 nanograms per ml. The thyroid profile was normal. The rest of the growth profile was normal, and the bone age was 3.5 years, which was lagging behind the chronological age and was commensurate with the height age. This brings us to the 5 possibilities, which I've already told you. It does fit the prototype of congenital syndromes. Autoimmune disorders can be ruled out in this case, because no autoimmune disorder in a child with adrenal insufficiency presents before 6 months of life. And as we have seen, this child presented on day 2 of life, day 1 of life. Inflammatory disorders can again be ruled out, because inflammatory disorders generally don't present in utero. Resistance syndromes can be thought of, but in this particular case, MC2R was a possibility in this case. But because of the very severe presentation, I was more in line with thinking of congenital syndromes. And like I've already said, congenital adrenal hyperplasia is a bit ruled out in this condition, because one, the child presented with normal genitalia, and second, the 17-hydroxyprogesterone values were quite normal for a child with a very elevated ACTH level. And this was a case which was veering more towards a congenital syndrome of pure adrenal insufficiency. And at this point of time, I asked for a genetic evaluation. My bet for this case was, I was looking at image syndrome. As you can see, she had intrauterine growth retardation, adrenal hyperplasia, and genital anomalies. She's too young to present with genital anomalies. They usually present around 14 to 15 years of age. But this case actually threw up a bit of a surprise. It turned out actually to be a side chain cleavage enzyme defect, a CYP11AM, where you had, the child was homozygous. She probably carried one gene from the father and one gene from the mother. And this on polyphen and looking at the genetic database, this was considered to be probably damaging, and this was a missense mutation. Even though it was considered an uncertain significance, the clinical features fit in very well with a CYP11A1 deficiency. And the classic presentation on the first day of life with very high ACTH levels and adrenal crisis and quick response to supplementation of hydrocortisone and fludrocortisone has been reported. Even if you look at the OMIM database, this has been reported. And growth failure is not a major part of this disorder, but a few cases have been reported with IUGR as well as growth failure. The classic presentation in this condition is with a neonatal adrenal crisis, severe adrenal insufficiency. Delayed puberty is a part and parcel of this disorder. Almost every child who presents with, female child who presents with this has a delayed puberty, and they have premature ovarian insufficiency. If the male child is usually born with a female phenotype, the so-called 46XY sex reversal. Because it was a female child, we could not actually see this X-sex reversal. As far as the management of adrenal insufficiency is concerned, we got a fairly good guideline from the Endocrine Society. This guideline is a combined adult and pediatric guideline, and it addresses problems adequately for both. As far as the guidelines for testing are concerned, and this is one area where I like the fellows to concentrate a lot. This is one debate, the chicken or the egg debate we've had for many years. How do you stimulate corticotropin stimulation? Do we use the 250 microgram test or do we use the 1 microgram test? The guidelines are very clear that you should be using the corticotropin stimulation, either the 30-minute or the 60-minute protocol. In fact, there was a divided opinion even as far as this guideline was concerned. Some people voted for the 30-minute, some people voted for the 60-minute. The consensus was on the 60-minute. As far as the doses are concerned, when the age is more than 2 years, the corticotropin stimulation dose should be 250 micrograms. 125 micrograms dose should be used in children of the age of 1 to 2 years. And if they are infants, the dose recommended is 15 micrograms per kg body weight. This does seem to be a bit of an overkill, but again, the guidelines are very clear on the fact that the ACTH level should be more than 300 picograms per ml, 300 picograms per ml before you start getting an adequate response from the adrenal gland. And they were very clear on the fact that you should not be using a 1 microgram corticotropin test, except if the synthetic ACTH is in short supply. Now that we're getting it manufactured in India, I don't think this is any more of an issue. In case you cannot have a corticotropin stimulation test, look at the morning cortisol should be less. If the morning cortisol is less than 5 micrograms per deciliter, with an elevated ACTH, which is more than twofold the upper limit of the reference range, this can be used as a surrogate for the corticotropin stimulation test. And it is this point I'd like a lot of fellows to concentrate on, because I've seen a lot of situations where even though you got a clear-cut case of adrenal insufficiency with ACTH levels of more than 1000, I do see a lot of pediatric endocrinologists going ahead with the corticotropin stimulation test. You have to consider this. There are no absolutes as far as corticotropin testing are concerned. When the ACTH levels cross 300 picograms per ml, there is no further need for doing a corticotropin stimulation test. This is given in the situations where the ACTH levels are less than 300 as a confirmatory testing. So again, the statement 3, corticotropin stimulation test is not mandated in every situation. You have to take it on a situation to situation basis because of the cost factor, the additional blood sampling in a child, and you have to take it on an individual basis and look at the plasma ACTH if it is more than twofold the upper limit of the reference range. And wherever possible and where affordability is not a factor, a simultaneous measurement of the plasma renin and aldosterone can give us an idea of the amount of mineralocorticoid impairment also, because adrenal insufficiency is never absolute. Even in very severe cases of adrenal insufficiency, the adrenal gland does retain a significant amount of capacity to secrete cortisol as well as aldosterone, and your treatment and your replacement should be based on the initial measurements of ACTH, cortisol, renin, and aldosterone, so that you don't overtreat the child. This is a brief guideline which has been presented in this particular brief algorithm. This again should be considered topically. Primary adrenal insufficiency, first divide it into either the CAH based or the pure adrenal insufficiency. Look at the 17 OHP. If it is very high, you're looking at CAH. If the 17 OHP is low, you're looking at genetic syndromes, especially in a young child, or an idiopathic adrenal insufficiency. If the age is more than 6 months of age, this is the cutoff for autoimmune adrenalitis. If available, do a 21-hydroxylase antibody. To the best of my knowledge, this is not available in India. A few years ago, I tried doing a study on this, but unfortunately, this was not widely available. If it is positive, you're looking at autoimmune adrenal disease. If it is negative, look at the CT adrenals. And depending on the CT picture, try to differentiate between infiltrative disease, infections. Malignant tumors are slightly uncommon in children. If the antibodies are negative and the very low chain fatty acids are increased, especially in a male, you're looking at a case of adrenoleukodystrophy. As far as the management is concerned, this has already been discussed in the previous talk. Hydrocortisone in 2 to 3 divided oral doses, highest dose in the morning, lesser in the afternoon and late evening. If it is CH, it's the other way around. The largest dose in the evening so that you suppress the morning surge of ACTH. Rarely, prednisolone can be used once or twice, especially in patients with reduced compliance, but this is a bit frowned upon in children. Replacement of fludrocortisone is 30 to 90 nanograms per kg per day. Usually, the requirement is around 100 micrograms of fludrocortisone. Clinic monitoring is essentially clinical. As far as the replacement of mineralocorticoid is concerned, you can do it with electrolytes. Wherever possible, do not use dexamethasone. One, because monitoring becomes difficult with dexamethasone, and you have a tendency to overtreat. Basically, as far as clinical monitoring is concerned, this is by weight, looking for postural high blood pressure, and looking at Cushingoid features. Cushingoid features indicate overtreatment. And coming to the context of adrenal crisis, whenever you suspect an adrenal crisis, the treatment of choice is an immediate parenteral injection, 50 to 50 mg per meter square of hydrocortisone, followed by a fluid bolus and 50 to mg meter square of hydrocortisone for 24 hours. Ideally, this should be given by continuous IV therapy, because if you give them 6 hourly injections, they can cross the renal threshold for reabsorption of hydrocortisone, and there can be a significant urinary loss of hydrocortisone. And make sure that you educate the patient as well as the parent. Teach them self-administration of glucocorticoids for the crisis, because you're not always going to be around. And wherever possible, give them an emergency kit, and also make sure that the child has a steroid label or a steroid bracelet, so that even people, if he has an adrenal crisis, the people around him can be aware of the fact that he's a case of adrenal insufficiency. As far as the newer advances in management of adrenal insufficiency are concerned, we've been hearing about them for the past 10 years, right from the time I was a student. We've had a lot of talk about Chronocort, which was a dual and slow release formulation of cortisol. But unfortunately, this has never been shown to give you a proper release of cortisol in clinical settings. Subcutaneous infusion pumps have been recommended for many years, but unfortunately, they're not clinically viable. In a few dexamethasone suppressed children, pulsatile subcutaneous cortisol replacement has been recommended. But again, this is not majorly practiced in day-to-day practice. Gene therapy has been recommended and has been tried out in a few clinical settings. And one patient at this point of time has also had an adrenal transplantation, because the main problem in the adrenal is with the adrenal gland and not at the level of the pituitary. And rituximab for cutting down on the progression of adrenal insufficiency has also been tried. And stem cell therapy has also been recommended in a lot of settings. But again, these are only in an experimental setting, and this is not really translated to clinical practice. And coming to the second interesting case, this is one case which I'd like to discuss with you. A 14-year-old 6-month girl who presented to the endocrinology OP. History of weakness of both upper and lower limbs since the past 2 years. Generalized weakness since the past 2 years. Postural dizziness since 1 year, and she's had delayed development of secondary sexual characters. Giving history of hyperpigmentation since 8 years. Pain in the calves noticed since 2 years, gradually associated with a walking difficulty. She's on follow-up with a neurophysician for all the neurological symptoms and was being evaluated for sensory and motor neuropathy. And unfortunately, she was on a follow-up with a gynecologist for delayed puberty for many years before she was referred to an endocrinologist. Luckily, she's not been started on any estrogen supplementation. She gave a history of third-degree consanguinity for 2 generations without any similar history of hyperpigmentation in the family. Examination height was around 25th centile and weight was less than the 3rd centile. At the age of 14 years, she was prepubertal. She had pallor, did not have goiter. She had typical hyperpigmentation over the face, lips, buccal mucosa, and the gums. No history of clitoromegaly, no evaluation, no clitoromegaly or features suggestive of virilization. And she had decreased power in all the 4 limbs, which was minor 4/5. At this point of time, the possibilities I would consider were, as always, B12 deficiency in all causes of hyperpigmentation, especially in the setting of neuropathy. But the standout diagnosis, the minute she walked in, I could understand that she was very well looking at a case of adrenal insufficiency. But one thing I couldn't explain in this was delayed puberty, except for the low weight. Probably we were looking at a hypothalamic amenorrhea because of low weight. The routine evaluation was normal. TSH was slightly elevated. Sodium was 128, potassium was 5.7, the cortisol was 4.58, and the ACTH was 1250, which clinched the diagnosis for us, and the ultrasound abdomen showed an infantile uterus. She was then started on hydrocortisone and fludrocortisone. Thyroxine was not replaced because cortisol deficiency can cause an elevation of TSH at the pituitary level, and she was asked to review after 2 to 3 months. On review, the hyperpigmentation had decreased. She felt much better, and the BP had normalized from around 90 to 70, 90/70 to 110/70. At the end of 6 months, the general condition was better. BP was being maintained. She had a height gain, but surprisingly, she did not have any development of secondary sexual characters. We had initially assumed to be because of a chronic disease. On re-evaluation, she had an FSH of 38.5, an LH of 17, and an estradiol of 34 picograms per ml. Provisional diagnosis, we thought we were perhaps looking at autoimmune polyglandular syndrome. Rarely they can prevent premature ovarian insufficiency before the onset of, this is very rare, this can present before the onset of menarche. She was then started on estrogen replacement. TSH had normalized now to 4 micro units per ml. And the thyroid antibodies were negative, and we were not in a position to do 21 hydroxylase antibodies. And the ovaries were still not visualized on the ultrasound abdomen. The karyotyping showed a trisomy 8, but I was unfortunately not convinced because trisomy 8 is what is known as Warkany syndrome, which does not have any specific features except for intellectual impairment. The subsequent CT abdomen showed again, which was ordered by the gynecologist, showed an infantile uterus and the ovaries were visualized. Achalasia cardia was noticed incidentally. And at the same time, while she was on follow-up with the neurophysician, the MRI brain showed atrophy or agenesis of the lacrimal glands, which brought us a diagnosis of Algro syndrome or AAA. We can even go ahead with genetic evaluation of the Aladdin gene, but when you have a setting of adrenal insufficiency, achalasia cardia, and alacrimia, the diagnosis is clear-cut. You can actually see the alacrimia there, which was the red arrow. However, I could not explain the delayed puberty, and because I was not convinced about the karyotype, I repeated it, and this showed a 47XXX. You were looking at a XXX syndrome. Basically, what happened here was that we were dealing with a very complex case. A XXX syndrome, which is not very common, but is still considered among the most common female chromosomal abnormalities in women. Classically, can present with epicanthal folds, hyperteliorism, upslanting palpebral fissures, which were seen in our patients. She had some amount of clinodactyly, did not have any pes planus or pes pectus excavatum. She had significant hypotonia. You can see that the power was decreased and the tone was also decreased. Did not have major joint hyperextensibility. Premature ovarian failure was there. She did not have the other features like a unilateral kidney and AITD. And the motor and sensory neuropathy for which she had been on follow-up with the neurophysician was actually because of XXX. She also had Algro syndrome. There are right now at this point of time, at the time of going to print, around 150 reported cases. Can present with adrenal insufficiency, achalasia cardia, alacrimia, and the 4th autonomic abnormalities. Can present as abnormal pupillary reflexes, poor heart rate variability, and the orthostatic hypertension. The dizziness which was seen in this case and which was assumed to be because of hyponatremia was also actually because of orthostatic hypotension. And this is because of mutations in the Aladdin protein of NPC. We had a combination of AAA and XXX. This patient had autonomic neuropathy because of AAA syndrome, sensory and motor neuropathy because of XXX syndrome, adrenal insufficiency because of AAA, and delayed puberty because of XXX. This was essentially a double case of triples, a AAA as well as the XXX. To the best of our knowledge, this is the only case of which has been literature till date. And this is why I said this is a very interesting case, the kind of thing you'll encounter only once in your lifetime. That's it. I've reached the end of my presentation, and if you have any questions, I'd be happy to take them. In conclusion, I'd only like to tell you that adrenal insufficiency is an extremely difficult disorder to evaluate. Now that genetic testing has become very common, our job is becoming easier. And this is one condition, except where the cause is very clear-cut, deserves always a genetic evaluation. But unfortunately, this is not feasible in a majority of our patients. Even as far as the genetic reports are concerned, I've got a wide variation in the genetic reporting from the various commercial Indian genetic labs. Some of the labs which do it at slightly lesser prices, I have generally found out that the genetic reports are far from satisfactory. And even when they report these genetic disorders, most of them don't refer to the proper databases. We would generally recommend using a recursive greedy algorithm, the kind of things which are seen only in the FIND database or the Polyphen 2. So until and unless bioinformatics get better with our commercial genetic labs, we are only going to get positive results in only 40 to 50% of our cases. That's it.
Thank you, Dr. Nagesh. Thanks for sharing that wonderful case. Actually, as you told, such cases we may see only once in a lifetime, and we all are fortunate to share that case.
To be very fair, it took me 2 years to work it up. The patient was irregular and it was extremely complicated.
So we will never think that there are two triples together. So I will start with the questions. Because of this inability to get or synactin sometimes, still it is difficult to obtain in some parts of our country. So people have started using acton prolongatum. Any experience with that?
No, I've used acton prolongatum extensively because I think since 2015, we have not had a lot of access to ACTH. So generally acton prolongatum is, we generally use it at an approximate dose of 25 units. 25 international units of acton prolongatum would be equivalent to 250 micrograms of synactin. This has to be given IM, but we give it with an insulin syringe. 16 units in an insulin syringe of acton prolongatum given at the deltoid. You give it at the upper end of the shoulder because that is where the muscle is the most subcutaneous. Wait for an hour. Especially in cases of adrenal insufficiency, I've got very good results with acton prolongatum. But now that you're getting ACTH again in the country at fairly reasonable prices, I think Sun Pharma is doing it. We have switched back to that, and results have been comparable to what we got with acton prolongatum. Depends on your case, because acton prolongatum is a multi-dose vial, and ACTH, which we are getting commercially, is now a single dose vial. But as far as I'm concerned, acton prolongatum, I've never had any problem with prolongatum. I think there's one article by Dr. Abhay Gundurti. He's a very close friend of mine. I think he did his DNP from Army R&R. It was one of the first articles which actually drew interest to acton prolongatum. That is the index article as far as acton is concerned. It's available in, I think, the JAPI journal. And it's a very good article. You can read it if you have the time.
Thank you. So, can you enlighten us on hydrocortisone infusion?
I'm sure you're all familiar with hydrocortisone infusion, right? Most of us, we generally calculate the body weight. You got nomograms for calibrating body weight only from the weight, not even from the height, because in a case who presents with an adrenal crisis, the best you can do for the child is you are going to weigh, check the body surface area and give an infusion. You give it in a 100 ml burette ACTH infusion. Ideally, you're supposed to, the first dose of ACTH, I think it can be a bolus dose because your priority is to elevate the cortisol levels as quickly as possible so that the child comes out of shock. And subsequently, like I've already mentioned, if you can give it by an infusion pump, it would be better because if you give boluses of cortisol, you are likely to have a sudden elevation in the levels of cortisol. This is going to exceed the renal threshold. it is going to exceed the binding capacity of your cortisol binding globulin and albumin. And a significant amount of this cortisol is going to be excreted in urine, so that you're going to be in a state of relative adrenal insufficiency. Where it is not possible, giving 6-hourly bolus injections is an alternative. Where possible, try to give an infusion. As far as the other question which I can see, I think you wanted to ask about self-injection of hydrocortisone. Children self-injecting, again, depends on the age. It's like children being taught to inject insulin by themselves. If the child is sufficiently good enough, he's conscious, he can self-inject HCT, but by definition, adrenal crisis is where you are no longer conscious.
Maybe we can teach the parents. Teaching the parents will be better. Yeah.
Parents is a good option, as well as the teachers. We can even recognize them to identify the signs and symptoms of adrenal insufficiency. Because school is one area where I think care in this kind of children is very lacking. I think even ISPAE has been trying to sensitize. Endocrine Society has also been trying to sensitize, but you also have to look at it from the teacher's perspective. Many of them are not very good at recognizing this.
And there is one question from Dr. Parvati. In a male infant with adrenal crisis and normal 17 OHP, other hormonal tests differentiating CAH from other causes of primary adrenal insufficiency, would ACTH and testosterone help?
Well, madam, if you're looking at a male infant with an adrenal crisis, your first priority should be to get him out of the adrenal crisis. Replace fluids. You can always draw samples, like I've already mentioned. The recommendation of the society is that you draw a sample at the time of presentation of an adrenal crisis. You draw a sample of 17 OHP, you draw a sample for ACTH, you draw a sample for cortisol as well as electrolytes. And if your ACTH is very high and your 17 OHP is still normal during a case of adrenal crisis, the diagnosis is clear-cut. You are looking at a case of pure adrenal insufficiency. If there is any controversy, the first priority should be to get him out of that crisis. Later on, like as was elucidated by Shaila ma'am, if the child is not very sick, take him for 24 hours of hydrocortisone, check the cortisol levels, give him an ACTH injection, and 1 hour after the ACTH, draw the 17 OHP and cortisol, and you can make a detailed evaluation later on. But the priority should be to get him out of adrenal crisis, and management is not very different. As far as my clinical experience is concerned, I've actually seen that in children with adrenal insufficiency, the dose requirements of hydrocortisone and fludrocortisone are much lower than what is seen in children with CAH. And I might be slightly controversial here, but as far as my experience with CAH is concerned, once the age is more than 10 years, I've generally found out that hydrocortisone does not work very well. The dose requirement of hydrocortisone goes up a lot, and I've started using dexamethasone in the past 1 year in children who are presented with CAH. Beyond the age of 10 years, there is a lot of evidence for the use of dexamethasone. A morning small dose of dexamethasone, somewhere to the tune of 0.2 to 0.3 mg per meter square. In slightly higher in cases of very severe CH, where you might even look at using a nighttime dose of dexamethasone. But as far as in these children, once you're beyond the age of 10 years, the traditional hydrocortisone and fludrocortisone therapy does not work. And if you increase the fludrocortisone doses, I've seen a couple of children actually presenting with hypertension. But again, that is open to conjecture, but this has often been neglected. The amount of evidence for the use of dexamethasone in this particular age group is pretty big. As far as adrenal insufficiency is concerned, I've never had the need of going beyond hydrocortisone in this age group. It is always milder than CH. Because the sex steroid component and the component of early puberty or precocious puberty does not enter a picture of pure adrenal insufficiency. But you'll have to look for ancillary features like adrenoleukodystrophy and AAA syndrome, and the use of controversial medications like Lorenzo's oil, which, as far as I have seen in case of adrenoleukodystrophy, has never worked.
Thank you, sir. And one last question.
Thank you, Dr. Nagesh.
For the want of time,
yes, I know we have Hari, we have exceeded, but I think we are going to be very controversial with Dr. Nagesh, telling that none of our children have received dexamethasone. They all have been very good controlled with hydrocortisone. I'm sure everybody will agree with me, because maybe the compliance was poor, especially in these children.
The COVID was a definite factor, ma'am. I think this has always been my suspicion that COVID was a definite confounding factor in this because most children were not on follow-up for almost 1 to 1.5 years.
That is very true.
Because
very
I don't want
all children, when they are not on follow-up.
Take home message for our fellows to use.
Yes. But I think that ma'am is absolutely right that COVID has been a huge confounding factor. Fellows, I would not recommend using dexamethasone. Dexamethasone is very tricky. Even I've run into major problems, but I've used it only in last resort.
So thank you, Dr. Riaz and
yeah, go on, Hari.
Thank you, Dr. Riaz, for coordinating, and Dr. Sri Nagesh for a wonderful talk. And we have one more session coming up entirely on CAH, I think. Yes. So all other doubts will get cleared in the next session. For the next session, we have the presenter, Dr. Chirantab Oza, and he is a clinical research fellow on pediatric endocrinology from Pune. And we have the case which will be the mentor here is Dr. Divya Lakshmi. She's associate professor and consultant pediatric endocrinologist from Sri Ramchandra Medical College, Chennai, and she's also an expert panel member for Tamil Nadu government for guidelines, writing the guidelines for treatment and surgeries of individuals with DSD. She is executive council member of ISPAE this year, and twice also in the past she has been a executive member, and she has got various publications in national and international journals. So over to you, Shiranta and Divya.
So once again, I mean, similar to adrenal insufficiency, all adrenal patients are kind of difficult to manage endocrine patients. One peculiarity about congenital adrenal hyperplasia is the dosing involved and the amount of long-term management that is involved in the management of these patients. Today's interesting case is on these aspects from how to diagnose a case, and then how to follow up the case, importance of the long-term follow-up, importance of compliance to the drug. And I think with that introduction, we will move on to the interesting case on CAH. Chiranta, please.
Yes, ma'am. Thank you so much. Good evening, everyone. I will be presenting a long-term follow-up of a case of congenital adrenal hyperplasia. I have been mentored by Dr. Divya Lakshmi for this case. So a 25-day-old male presented with complaints of failure to thrive with weight of 2.4 kg against birth weight of 2.9 kg, with complaints of vomiting, lethargy, hyperpigmentation around genitals, axilla, and umbilicus, and with normal male genitalia. The laboratory reports were of hypoglycemia, a sugar of 38 milligram per deciliter, hyponatremia, sodium of 127 milliequivalents per liter, and hyperkalemia, a potassium of 7.2 milliequivalent per liter, with negative septic screen that raised suspicion of adrenal crisis. And the case was identified as salt wasting CAH by the following reports. The value of 17-hydroxyprogesterone was high, 84 nanogram per milliliter. Testosterone was 512 nanogram per deciliter, and ACTH of 98 picogram per ml. So the diagnosis of salt wasting CAH was made, and it was confirmed on genetic analysis, which showed a mutation of CYP21A2 gene that was significant with autosomal recessive inheritance. After managing the acute condition, the patient was discharged on oral hydrocortisone at a dose of 18 milligram per meter square per day, oral fluoricod at dose of 100 microgram per day, and salt supplementation of 1 to 2 gram per day. The patient was asked to follow up regularly for anthropometric, blood pressure, and electrolyte monitoring. This growth chart shows the follow-up of child up till the age of 1 year. The oral hydrocortisone was adjusted as per body surface area to 12 to 15 milligram per meter square per day. Electrolytes revealed low potassium and a plasma renin activity of 0.02 nanogram per ml per hour, following which the dose of oral hydrofluorocort was reduced to 75 micrograms per day. Salt supplementation was stopped after infancy, and parents were taught about the emergency management. Upon following up the child at the age of 4 years, weight gain was noted with decline in height velocity, which was possibly due to overdose of steroid, and hence the dose of steroid was reduced. Along with routine workup, signs of steroid toxicity were also checked on subsequent follow-ups. At the age of 6.5 years, a height spurt was noted. At that time, the SMR of the patient was A1, P2, G1, and testicular volume was 3 ml on both the sides. The bone age was found to be 6.8 years, that is not significantly advanced. Serum electrolytes were normal. Testosterone was 24 nanogram per deciliter, and 17-hydroxyprogesterone was 12.4 nanogram per milliliter. Hence, the cause was considered to be underdosing of steroids. However, on following up the child at age of 8 years, the increase in height velocity persisted. At that time, the SMR stage of the patient was A2, P3, G2, and testicular volume had increased to 10 ml on both the sides. The bone age also had increased and was found to be 9.8 years. The serum electrolyte and 17-hydroxyprogesterone levels were normal. Testosterone was 88 nanogram per deciliter. Development of central precocious puberty was suspected, and a GnRH stimulation test was performed. On performing the GnRH stimulation test, the post GnRH LH values at 1 hour were 7.2 micro-international unit per ml, and the diagnosis of central precocious puberty was confirmed. The patient was started on GnRH analog 11.25 milligram deep intramuscularly to be given every 3 months. The growth rate of the child was normal with no further increase in testicular volume thereafter. The patient had another height spurt at age of 11 years. At that time, the post-GnRH injection LH values were less than 3 micro-international unit per ml with no increase in the testicular volume, and hence the cause was thought to be underdosing of steroid or poor compliance. At the age of 11.5 years with a bone age of 12 years, the GnRH analog was stopped. Following which, normal pubertal growth spurt was noticed, and the patient achieved a final height of 168 centimeter, that was in the mid-parental height target range of 165 to 177 centimeters. During his teen years, the patient was quite irregular with his steroid intake. The testes were palpated and were found to be hard in consistency and nodular. The ACTH level was more than 1000 picogram per ml on steroid twice, suggesting poor compliance. Due to abnormal consistency of testes and poor CAH control, the development of testicular adrenal rest tumor were suspected, and an ultrasound was performed. The ultrasound image showed the following results, and the diagnosis of TART was confirmed with the ultrasound and Doppler. So in summary, a 25-day-old male infant presented in classical adrenal crisis due to salt-wasting CAH, which was confirmed on genetic analysis. The height spurt in a patient of CAH may be either due to underdosing of steroid or due to development of precocious puberty. Poor compliance to steroid therapy may lead to development of TART, which may sometimes be identified clinically by palpating the testicular consistency and nodules. And there is recent evidence that suggests that TART are quite common in boys with CAH and can be recognized as early as 3 to 5 years age. Good control of CAH and adequate ACTH suppression reduces the chances of development of TART. So for the discussion bit, ma'am,
I think there are no questions till now. Yeah, I think we can proceed with our discussion slides.
Okay. The first part of discussion is how to monitor and follow up a child of CAH. So on basis of the recent guidelines, the frequency of monitoring has been recommended to be monthly for first 3 months, 3 monthly thereafter till age of 18 months, and 4 monthly after the age of 18 months. The clinical features must be monitored in each visit, and they include height, weight, BMI, blood pressure, sexual maturity rating, development of edema, hepatomegaly, and any signs of glucocorticoid or mineralocorticoid overdose. The biochemical investigations that need to be done are 3 monthly serum electrolytes and 17-hydroxyprogesterone, and annually testosterone and plasma renin activity. The radiological follow-up annual bone age assessment is recommended.
Welcome, Dr. Anna. You are muted.
Hello.
So the case presentation of CAH is going on, like we are towards the end of the presentation. So we'll welcome again, like we'll get back. Yeah, continue, Chiranda.
Yes, ma'am. So the next part of our discussion is about the stress dosing. So increase in glucocorticoid dosage to double or triple of the maintenance dose is recommended for situations like febrile illness where temperature is more than 38.5 degrees Celsius, gastroenteritis with dehydration, major surgery accompanied by general anesthesia, and major trauma. Increased dosing is not needed for everyday mental and emotional stress and minor illness and or before physical exercise. Educating the patients and their guardians as well as close contacts on adrenal crisis prevention and increasing the doses of glucocorticoid but not mineralocorticoid during intercurrent illness is important. And equipping a patient of CAH with glucocorticoid injection kit for emergency use and providing education on parental self-administration or lay administration of emergency glucocorticoids. The recommended stress dose of hydrocortisone as per age is for infant and preschool children 25 milligram, for school age children 50 milligram, and 100 milligram for adults. The next part of discussion is what is the role of GnRH analog in congenital adrenal hyperplasia, which is complicated by central precocious puberty. So bone age at the initiation of GnRH analog therapy is the most important factor that will affect the predicted adult height. GnRH analog treatment of CAH and CPP was first described in 1985 in a study that involved 8 CH participants who were started on glucocorticoid treatment at advanced age. All the 8 of the participants developed central precocious puberty, 4 of which were treated with LH releasing hormone agonist and 4 were monitored as control subjects. While there was no difference in target height and final height in the treatment group, the final height in control group fell behind the target height. Another study suggested that GnRH analog should be added to hydrocortisone and fludrocortisone treatment and should be maintained for at least 2 years. There is very limited data from India, but a study from North India has showed significant improvement in mean predicted adult height after 3 years of treatment with slowing of bone age. However, it was also noticed that the decrease in height velocity was not as pronounced as in developed countries. The next part that we would like to discuss is the development of TART. So TART are a common complication in male patients with CAH with an average prevalence of 40% and are the most common cause of infertility in male patients of CAH. TART have an increased prevalence during puberty and adulthood and have pluripotent cell type as origin. The differentiation between TART and Leydig cell tumor is quite difficult. ACTH seems to be the most important stimulating factor in the development of TAT in patients of CAH. The first choice of treatment for TAT is intensifying glucocorticoid treatment to suppress the ACTH. Surgery is only indicated when there is complaint of severe pain, as it is not able to restore fertility. And lastly, we would like to talk about the role of genetic diagnosis in cases of CAH. In individuals with CAH, genotyping is recommended when result of adrenocortical profile after a cosintropin stimulation tests are equivocal, or cosintropin stimulation test cannot be accurately performed, or for purposes of genetic counseling. Genotyping of at least one parent aids in the interpretation of genetic results because of complexity of the CYP21A2 locus. In children with CAH, adolescents transitioning to adult care, adults with non-classical CAH on diagnosis, and partners of patients with CAH who are planning pregnancy, genetic counseling is recommended. In Western country, genetic counseling is routinely done for all the patients of CAH to explain the inheritance and the risk of development of CAH in the future generations, as well as in the next planned child for the couple. In India, however, due to monetary restraint, genetic testing is not done as frequently as it should be. And it is ideal for all the cases of CAH to undergo genetic diagnosis. So these are my references for the discussion bit. I would like to thank all of you for your patient hearing.
Thank you, Chirantu. That's a very excellent presentation, and it's like one of the kind learning experience in a single case. Showing all the complications that can possibly occur in a CAH patient. So, so again, as a take-home message, and I would like to appreciate the efforts put in by Dr. Kadilkar sir, to have long-term follow-up for such a single patient. So I think that's Rashia's workup for the case. And I think to conclude, it's very important that, one thing is the diagnosis part of CAH, which could be tricky. And even, and then we cannot simply sit and relax, once you diagnose a case with CAH, the balance that you need to, attain to have a normal clinical response by looking at the height, weight, and the BP measurements, and also with the biochemical parameters. It's kind of walking on a tightrope. So I think we have a expert speaker today with us. I think who will enlighten us on all the recent advances, diagnosis, and the long-term follow-up, which is her area of interest as well. So thank you, Chiranta. I'll just quickly see whether there are any questions. Yeah, I think there are no questions. Thank you very much.
Thank you, ma'am. Thank you so much.
Shaila ma'am, any questions?
No, I think you can continue. I'll get back later. I've just reached the place. Yeah.
Okay.
Thank you.
Nishad, please share the slides. So we are moving to the next and the last session of today's ACES meet. So it's indeed a proud moment and a pleasure inviting Dr. Anna Nordenstrom, who is a professor and senior consultant in pediatric endocrinology. She is the team leader at the Astrid Lindgren Children's Hospital, Karolinska University, and Karolinska University Hospital and Karolinska Institute, Stockholm, Sweden. And she has been given the in charge of the Swedish screening program for CAH. And she is part of the European Reference Network for Rare Endocrine Conditions, ENDO-ERN, in which she represents her university. And she's also an active member in the IDSD, ICAH, and Eureka, which is European Registries for Rare Endocrine Conditions registries. And her areas of interest are CAH and DSD. specifically the epidemiological registry studies, long-term outcome in CAH, and correlating the results to the severity of the disease, especially with the 21-hydroxylase deficiency genotype. And she is also interested in the studies of individuals exposed to prenatal dexamethasone with and without CAH. So indeed, I have been lucky enough to hear Dr. Anna's talk in a couple of meetings. It's very resourceful and enriching, and we are much honored and privileged to have you in our platform, Dr. Anna. The stage is yours, and over to you.
Thank you very much, and thank you for this kind introduction. Now I will try to share my screen and also to use this mode. Okay, thank you for letting me talk today. I'm going to talk about CAH diagnosis and management, some recent updates. I think some of what I will say will repeat what the previous speakers have said, but I think I will just go through. So the congenital adrenal hyperplasia is in more than 95% of the cases caused by the 21-hydroxylase deficiency, which blocks the steroid synthesis, both for aldosterone and for cortisol. So the patient ends up with aldosterone deficiency and cortisol deficiency. Aldosterone is present in 100 times less concentrations, which I will come back to a little later. It makes a difference for simple virilizing and salt wasting CAH. And at the same time, there will be a buildup of the metabolites before the block, which will lead to an increase in 17-OHP and androstenedione and the other metabolites, which leads to an increase in testosterone and other androgens. The CYP21A2 gene, the 21-hydroxylase gene, is located on chromosome 6, and it is situated in tandem with a pseudogene, the CYP21P, which is to a large extent homologous with the active gene, but it contains a number of inactivating mutations. And since the HLA class region is a very active region for recombination and differences in the genetic workup, we think that that's why a large number of mutations are transferred from the pseudogene to the active gene. All in all, there is more than 200, I think even more than 300 now, mutations in the CYP21 gene described. But in 95% of all mutations, it is one of 10 point mutations that are derived from the pseudogene or a deletion of the gene. And this is very important information because since this is a recessively inherited disease, we can look at the two mutations that the patients have and make very nice genotype-phenotype correlations. So if we have a situation where both alleles have completely abolished enzyme activity, that is null mutations, then the patient will have the most severe form of CAH with salt wasting and die in the neonatal period unless they're treated. In the case of I2 splice mutation, or I2G as it's called today, there is slightly more enzyme activity, just a percentage or so. And that is enough to produce a little bit of aldosterone, and that has some effect on the salt wasting. So these patients may survive longer. And in both these cases, and also in the case of the I172 and the P30L, which are the most common simple virilizing mutations, the patients are, or the female fetuses are virilized prenatally, and they're born with virilized external genitalia that can be graded according to the Prader score from 1 to 5, depending on how much clitoral enlargement and how much posterior fusion of the labia majora they have. In the case of the non-classic CAH, there's no prenatal virilization, and the patients have no risk of developing salt crisis, but they will develop hyperandrogenism over time with pseudopubertus precox, growth acceleration, hyperandrogenism, infertility, hirsutism, or PCOS. So why are then patients so much prenatally virilized? Well, we think of the steroid production in the adrenal cortex. It goes from cholesterol and all through these steps and ends up with aldosterone and cortisol, and the 17-OHP increases. But a few years ago now, it was recognized that the 17-OHP can be converted through a number of steps to DHT, the dihydrotestosterone, which binds to the androgen receptors about 10 times stronger than testosterone, and is also required for the virilization of external genitalia in a male fetus. And this will probably be one of the factors that increases the virilization also in the female fetuses with CAH. But this is not the end of the story. The steroid production pathways are very interesting, and Kamrath and Woody have published a series of papers lately where they describe how complex the steroid production is. Rather than being a two-dimensional system, it seems to be a three-dimensional system now, where the 17-OHP also produces the 21-deoxy cortisol, which is pathognomonic for 21-hydroxylase deficiency, and that can be converted in several steps, and also other ways. We can have the production of 11-keto-testosterone and 11-keto-dihydrotestosterone. And these two compounds are very interesting. They bind just as well to the androgen receptor as testosterone and DHT. And so that also increases the virilization in patients with CAH. And it may be that we have very more personalized systems where we can see that some patients have a tendency for this production and some don't. So this will maybe explain some of the differences we see in the symptoms in patients who may also have the same CYP21 genotype. So how do we diagnose the patients? Well, the best way to diagnose them is to diagnose them as early as possible. And that's why neonatal screening has been implemented in an increasing number of countries. It prevents neonatal death, especially among boys with salt-wasting CAH. But the problem is that it also has relatively high false positive rate with increased 17-OHP in preterm infants. So the gestational age needs to be considered. And also stress in the neonatal makes the 17-OHP increase, of course. We see, I just have shown a picture here on how the incidence of salt-wasting CAH and non-salt-wasting CAH changed when screening was implemented in Sweden in 1986. And I think the interesting thing here is that it was not only that the salt-wasting boys with CAH increased, but also the girls. So it's very possible or likely that also girls with virilized external genitalia were diagnosed as hypospadias and then died in the neonatal period before they could see a urologist and were never diagnosed. The incidence of CAH differs. It's in most of the world, it's about 1 to 10,000, which is the case in Sweden, and 1 to 40,000, which is the case among Black Americans. But I have read up on India and realized that in different regions in India, the incidence differs between 1 in 2,000 and 1 in 10,000. So how do we use the 17-OHP in the screening of CAH in Sweden? Well, we have seen, as you see on the right panel here, that the level of 17-OHP correlates very well with the genotype. And this is very important and useful information when I get a screening result with an elevated 17-OHP and I call the clinician in charge of in the hospital where the child is born, then I can say, well, this is most likely a salt wasting CAH, and you need to see the child right away and start treatment after you have taken confirmatory samples. Or I can say this may likely be a false positive, and we can just we don't have to rush. And you can see here also that for the ABC, that salt wasting, I2 splice, and simple virilizing, we have mostly classical CAH and CAA in Sweden. And so if the child is not diagnosed through screening, how do we make the diagnosis? Well, I think the previous speaker talked about that. We can either take a basal morning 17-OHP, or we can make a stimulated test. And usually we say that if a morning level is about 6 nanomoles per liter, then that indicates we need to do some more investigations. But also with the stimulation test, we can see that the most severe forms have higher 17-OHP levels and lower cortisol levels, as you see in the upper panel here. For menstruating women, it's important that the sample is taken during the follicular phase. So what about the treatment? Well, in children, we use, as the glucocorticoid, we use hydrocortisone since it affects the growth less than the more longer lasting prednisolone, for example. And the dose is usually between 10 and 15 milligrams per square meter a day. And we divide it by 3, or increasingly we use 4 times a day as a dosage to be able to lower the total dose, actually. And as a mineralocorticoid, there's only one choice. It's a fludrocortisone. And in the small children, it's often divided by 2, but it can also be given once daily. And during the first 1 year at least, maybe even 2 years, the child needs some extra sodium chloride. Then for the girls, there's the issue of surgery, and this is increasingly discussed now at least in Europe. This is a large issue that we would need an extra half hour to talk about this separately. So I won't go into this anymore today. But the treatment, as was mentioned before, also is a very difficult balance between overtreatment, which results in reduced growth velocity, and undertreatment, which results in advanced bone age at the same time as you see an increased growth velocity. And in both cases, you have a reduced final height. And in the meta-analysis that have been published, they came up with minus 1.4 standard deviation scores. However, in Sweden, where we monitor these children closely with 24-hour 17-OHP levels, we see that many of these children have a final height similar to their target height. One thing that is very important to be aware of when you treat children and adolescents with CAH is that during puberty, the possibility for the patient to reactivate cortisone to cortisol diminishes. With the increased IGF-1 growth hormone, there is an increased insulin resistance, and the 11-beta HSD type 1 in the liver, the activity decreases. So you need to supply more cortisol because the cortisone is not as well reactivated to cortisol. So it's not uncommon that the adolescent in mid-puberty will need a considerably higher dosing of hydrocortisone. You, as a child, may have used 10 milligrams per square meter, but in mid-puberty may need 18 or even 20 milligrams per square meter. Another aspect that is important is what happens with the adrenal medulla when you have CAH. We know that the differentiation of noradrenaline to adrenaline is dependent on the local cortisol production in the adrenal cortex, so that the adrenal medulla can differentiate and the chromaffin cells in the adrenal medulla can differentiate. So it has been shown, this is a study by Murky and all, that salt wasting CAH, they produce very little adrenaline, simple variolacing a little more, and non-classic maybe a little more, but if they're not treated, even more, in the same level as controls. And so this, of course, increases the risk for hypoglycemia, especially in the small children. And it may also lead to stress vulnerability, but that has not been shown. And this study that was published a few years ago now in Germany looked specifically at hypoglycemia in younger children. And this is very important, since the symptoms of hypoglycemia that we're used to interpret as hypoglycemia, it's being pale or tremor and things like that. They're all caused by adrenaline. So when you have an adrenaline deficiency and hypoglycemia, you may only be tired, or you may only have a low temperature. So when they looked at this, they also gave the families a measurement possibility to measure glucose. But during the first year, they saw salt loss, but no hypoglycemias. During second year, there was more hypoglycemias, also in combination with salt loss. So, but after 4 or 5 years of age, there was no more hypoglycemia detected. So this is an age-related thing. But when we looked at the severity, when they looked at the severity of CAH, I think it's very interesting that the null genotype group, they didn't have any hypoglycemias detected. It could, of course, be that they didn't even detect it, but it can also be that they're treated with somewhat higher levels of hydrocortisone and escape hypoglycemia because of that. Of course, during the first year of life, children are given food very often anyway. So then the hypoglycemia is less common. So the emergency treatment, as we heard just a little while ago, depends on fever, double or triple or even quadruple the dose. And then if there's a low temperature, one should think about hypoglycemia. In Sweden, we also use IV hydrocortisone called Solocortef. I don't know if you have that available in India, but it's very good to have as an emergency treatment if you have vomiting and you cannot take the oral medication. We educate all the patients in how much Solocortef they should give themselves, IV or IM, intramuscularly, if they're somewhere where they can't go to a hospital fast enough. We also have now a system where we say that during surgery, the hydrocortisone should be administered IV continuously during the surgery when you cannot really predict how long it takes. This is very handy, and give 2 to 3 milligrams per square meter per hour. The alternative, of course, is to give the same total dose, but divide it times 3 or 4 over the day of surgery, and then taper. And we also give out these cards to everyone with cortisol deficiency so that healthcare personnel will know that the person has this problem. And we also give this card so that everyone will remember how much the initial hydrocortisone dose should be increased. I also wanted to just say a few words about new treatment, because there's now a lot of activity around treatment strategies and development of new medications. And there are two main strategies. One is to improve the diurnal distribution of glucocorticoid and thereby decrease the ACTH and thereby the androgen production. And so you will then reach a better balance. The other strategy is to decrease the androgen production by the adrenals. And then this enables a replacement therapy with lower doses of glucocorticoid, because then we don't need to increase the glucocorticoid to such a level that it decreases the androgens enough. And the first medication that has been registered and for the use in CAH for this purpose is FMODI, or it was called Chronocort during the development period. It's a modified release hydrocortisone that it has a slow release and is given twice daily. You give 2/3 of the dose in the evening at bedtime, or even 3/4 of the dose, and then 1/3 or 1/4 in the morning. And in 122 patients, half had the slow modified release hydrocortisone, and half had the standard dose. It was clearly shown that the increase in 17-OHP in the early morning hours was decreased, and the same for the androstenedione. There was no adrenal crisis in the modified release hydrocortisone group, and 3 women were even pregnant during this time, although it was not planned to be so. And 4 partners for the men with CAH in the study was also pregnant, but they were all in the modified group. The dose recommended for adults is 15 to 25 milligrams per day, and for adolescents, it's 10 to 15 milligrams per day. But there's no preparation available for children. But over time, the dose had to be decreased. And this is, I think, interesting. They saw that in females, over time, there was an increase in lean body mass and possibly also a decrease in bone mineral density. And I think this is something we need to be aware and careful about. Unfortunately, FMODI is a very expensive drug, and in many countries it's not available because it's not registered yet, but in other countries it's not covered by the healthcare system, which is the case in Sweden. So it's very expensive for the parents to use, or for the children and patients to use this. But I think this also gives a take-home message for all of us. It tells us that the diurnal rhythm of hydrocortisone supplementation or replacement is very important. In Sweden, we use the 17-OHP for the screening to do capillary home testing. And so we measure the 17-OHP in filter papers in the morning, before the dose, and in the midday before, and in the evening, and so on. And for this girl, she had a hydrocortisone dose of 15 milligrams per square meter a day. She had the hydrocortisone was divided by 10 milligrams in the morning, 7.5, and then 7.5. And with this dose, which is not a small dose, she had very high 17-OHP levels. But when I looked at this, I realized that she was taking what I think should be a lunch dose. She was taking that when she came home from school. And I asked her to take this at lunchtime instead. And you see how much the 17-OHP in just a few weeks with this new regimen decreased. So without changing the total dose per 24 hours, just changing when it's given, you can have a much better effect. And I think the next step here would be to decrease the evening dose. And it may be that we have just the same effect anyway. So other new treatment is the corticotrophin releasing factor receptor 1 antagonists. They're not in clinical use yet, but the idea with these is that when you decrease the CRF, then you decrease the ACTH and you decrease the stimulation, so that there will not be the same androgen production from the adrenal glands. But of course, you need glucocorticoid replacement. It's called crinecerfont and tildacerfont, and there is phase 2 and phase 3 studies are ongoing in adults and actually in prepubertal children. So these may be of interest a little bit further in the future. Then another one is the enzyme inhibitor abiraterone. It's used in prostate cancer and it inhibits androgen production. And it enables lower replacement doses of hydrocortisone, but it does have some risks. And there is a pediatric study just started. Fertility, I will just say a couple of words of that. Fertility in women with CAH is dependent on, partly at least, on the 17-OHP that binds to progesterone receptor and acts as a mini pill and interferes with endometrium, cervical mucus, and also the ovulation. So then a higher glucocorticoid dose is needed. And the recommendation is to lower the progesterone below 2 nanomoles per liter. In men with CAH, overtreatment and overweight will result in low adrenal androgens. Undertreatment and increased adrenal androgens will also result in low FSH, LH. So LH is important because you need to have intratesticular testosterone production for the Sertoli cells to function properly. And also with the high FSH, LH, you will, with the increased ACTH that results from undertreatment, you also get the TARTs, as the previous speaker was mentioning. And the TARTs, of course, is a large problem for future fertility. And also for pediatrics and for all of us seeing also adolescents, this is a very important issue because the development of TARTs can be seen also in children. It can be developing faster because of poor compliance, but it is also related possibly to the severity of the CAH. And depending on how good an ultrasonography you have, the incidence differs. So this is just to show how the staging of the TARTs can be made. And a potent steroid may inhibit this. So how do we know if the androgens that we measure, the testosterone we measure in a man with CAH is coming from the adrenals or the testis? Well, we can measure the ratio between androstenedione and testosterone. If it is very low, then the testosterone from the testes is high, and that's normal. If it's very high, then it's of adrenal origin. So the LH and FSH and these ratios are very helpful. So in conclusion, there are new treatments on the way, but with early diagnosis and careful monitoring and how the dose is divided over the day, it is possible to achieve good control in CAH also today. And thank you for your attention.
Thank you, Dr. Anna, for the spectacular lecture, as always. So there are a couple of questions that have been asked by the delegates.
Okay.
But I would like to ask you a question, which I have a case scenario that I have encountered recently. Like in a newborn who is presenting with salt wasting, and the 17-hydroxyprogesterone and the cortisol comes as borderline, like a borderline low cortisol and just on the borderline 17-OHP. And we need to start the child on steroids like, when do you kind of like, would like to work on ACTH stimulation test or the genetic testing in such a patient? Like,
oh, you mean if the 17-OHP is not that elevated?
yes.
Well, in my experience, the 17-OHP increases over time. So if you have a first sample in the screening with 17-OHP that is just a bit elevated, I would not start the treatment unless the child has other signs and symptoms that would make me suspicious of CAH. I will just take a second sample and see if the 17-OHP is going up. But if the 17-OHP is very elevated, then of course it's indicated to start treatment right away. And sometimes it's said that if you find a child that doesn't have any clinical symptoms of CAH, then you can start with the regular dose from the beginning. But my experience is that it's very difficult to decide if a newborn has no signs and symptoms of CAH, if they're tired or not, or if they're not gaining enough weight or something like that. So in my experience, it's good to start with, for example, 5 milligrams of hydrocortisone times 3 for a day or two, then decrease to 2.5 times 3, and then within the first week, then you can go into a dose that you think is more the regular dose that you will have for a while. For example, 1 milligram times 3 or so.
And the next question is from Dr. Hari. So is it possible to get hypertension in a case of 3-beta hydroxysteroid dehydrogenase mutation?
Oh, when you have the mutation with no treatment or with treatment?
I think he
Yeah, with treatment, but
with
presenting
treatment
as hypertension, yeah.
Yeah, with treatment, you can always get hypertension. The problem, I think that very often we give sodium chloride and we give fluorocortisone. And sometimes it's very difficult to get enough sodium chloride in the child. It's easy that they vomit a lot. And then it's usually good to increase the fluorocortisone dose, at least during the first half or maybe first year. But then you need to be careful and lower the dose promptly, because otherwise the child will develop hypertension.
Even if the child is off fluorocort after the hypertension are detected?
Yeah, well, if you lower, if you have a severe 3-beta HSD, then of course they will be salt wasters. And then so you need to give them both sodium chloride and fluorocortisone. But if you overtreat with fluorocortisone when they are about 1 or 2 years of age, then they will develop hypertension. But if you go back to a lower dose, within, not immediately, but within a few months, they will go back to normal blood pressure. Have you had a different experience?
Yeah, I have got a patient who presented with salt wasting, and they started on glucocorticoid as well as fluorocorticoid. And he was undergoing corrective surgery. So I got a call from the anesthetist that he has got a severe hypertension, and the blood pressure was around 160 systolic, so unmissable hypertension. So we were quite surprised by that. So I stopped fluorocord, and after perhaps 6 months, we sent genetics, and it came out to be 3-beta HSD. And the child had ambiguous genitalia. He is 46XY DSD, still has got hypertension only on hydrocort.
Okay.
2.5 years now.
That's interesting. Yeah, I'm wondering if he had some other problem as well. Yeah,
and I've got.
I have no good explanation for this.
And I have got 2 such cases now.
Okay.
So this
3-beta HSD is not common in Sweden. I think we have a handful in all of Sweden. So I don't have much
I've
experience.
got 2 mutation positive 3-beta HSD, both having hypertension.
Oh, that's interesting.
So we'll move to the next question. Like it was asked by Dr. Raghupati, he's a senior pediatric endocrinologist in India. So his question is, are there any specific problems observed by you in achieving good control of CAH in children above the age of 10 years with the hydrocortisone and fluorocortisone alone exclusively given for treatment? Or in other words, he's trying to ask, like, have you encountered like the need to use more potent glucocorticoids?
I think, well, sometimes I've realized in my experience, if the child has been sort of outgrowing the dose and been out of balance for a while, it takes a lot more increased dose for a while to go back to a situation where you're back in balance. It can be that you get that I get the feeling that I sort of I'm always behind in increasing the dose. I have not been using prednisolone, and I'm not using the stronger dexamethasone either. And we have also shown in the Swedish population, we haven't published that yet, that even if we give a small dose of prednisolone in the evening, which some people have done previously in Sweden, then the children they have a shorter final height, and they also have a higher BMI. So also with a very small dose of prednisolone, like 1.5 milligrams in the evening, they gain weight and grow less. So I'm reluctant to use anything else than hydrocortisone.
And the next question is it possible that the adrenal insufficiency can be transient and it resolves spontaneously over time?
The adrenaline?
Adrenal insufficiency.
Oh, the adrenal insufficiency.
It could be like a transient and it resolves over a period of time.
I think it is very interesting. When I talk to my adult colleagues, I've heard from several that also patients with salt wasting CAH that are, diagnosed with genetically and everything, that as adults, they stop taking the medication. But it's never without symptoms, but in one case, the patient had huge adrenals. And I think that Maria New also has published a case like that. I don't think that the disease itself resolves, but I think for some reason that we cannot really explain, they have some metabolites that can take over the cortisol and aldosterone function, I think.
I think the last question will be, if a CAH child presents with a short stature and you find the bone age is advanced, what are the, how to evaluate in such case, and what are the treatment options?
I think it is very interesting that if the bone age is very advanced and we start treatment with hydrocortisone, it's not seldom that we see that the bone age doesn't change. It's like they make a halt for the bone age advancement until they reach an older age, and then they continue to grow. But if it is an extreme situation, there are, of course, other possibilities. I have used aromatase inhibitors in a couple of boys that had such a problem. But of course, that may have other risks. And to stop the puberty, if the puberty is very early, then that could have other psychological effects as well that could be of positive effect for the patient. I think it is difficult when the patients are diagnosed late. I think that's one of the big benefits with the screening, that we identify them early, and there's a lot of symptoms that can be avoided. Yeah. I think this has to be discussed from case to case. Yeah.
Yeah, yes, ma'am. Shaila, ma'am.
Yeah. Thank you, Dr. Anna. Excellent presentation. It was wonderful. I think we are also having a good discussion. Mine is very, very simple question. What level of 17 OHP around pivotal age group should we accept as okay for continuing the same dose of hydrocortisone? Because lot of adolescent or adult endocrinologists use even 10 as norm during follow-up. So this pivotal and adolescent age group, what should be our cutoff or 17 OHP levels, please?
I think it depends on when you take the sample, of course. I have more and more started to use what we call the 24-hour profile, when we use the same filter paper cards as we do for the screening. And of course, then we have, I shouldn't really call it quick and dirty, but that's what it is with the screening. 17 OHP is not as exact as the 17 OHP that you get from the clinical laboratory, of course. But I think that it depends on at what time you take the sample that you want to assess. If I try
Normally
to take the sample before the morning dose. Yeah, before the morning dose.
Yes.
Before the lunch dose, before the possible afternoon, before the evening dose, and then the morning dose again. I usually try to get 2 morning doses. And then I think that the 17 OHP in the morning should go up. It should be elevated compared to the normal levels, although I want all the other ones to be low. So I think that it's if all the 17 OHP levels, also the one in the morning, is within the normal range, I think the patient is probably overtreated.
So is there any
I'm
magic
just currently
number?
trying to figure out what the level should be. You need to correlate it to the laboratory that you're using, because all laboratories have a little bit different levels. And also I have the 17 OHP level in the screening. I'm also thinking that maybe it would be interesting to see if we could use some of the other metabolites, like the 11 keto, if we could see if the 21 deoxycortisol is varying in the same fashion, or if we can use some of the other metabolites as well. Maybe we can get a better picture.
We don't use filter paper after the neonatal period all over India. That is one thing. Yeah. And also most of the time we use only morning 17 OHPs, and we also don't use 24-hour 17 OHPs. So
but you take for the clinical laboratory. You do it at the clinical laboratory then in the morning?
Yes, in the morning the sample is done in the lab, and then the assay is done for 17 PSA.
So what level do you usually accept in the morning?
Usually, if we usually take as 5 nanogram.
Oh well, you'd use nanograms per deciliter.
Yes.
Okay.
Yes.
Yeah, we use nanomoles per liter, so that's different. But I know that, for example, Deborah Murky's group in NIH, they take a morning sample at 8 or 9. But to me, that doesn't really make any sense. You need to know when in relation to the dosing and so on.
Okay. So I think we should do some few children doing a pre-dose testing of 17 OHP and see the comparison, how they do. Yeah, sure. Thank you very much. Thank you.
Thank you, Dr. Anna. We really appreciate your commitment, and thanks for accepting to be our guest speaker in this forum. Yeah, I mean,
Thank you. It's a pleasure.
You know, it's a privilege to have you as a speaker with us. Shaila ma'am, would you like to?
Yeah, no, even with her social commitment, she was on spot. We were a little concerned. She had not joined, but she was on spot and she joined. Thank you very much. We appreciate
Thank you very much. It was a pleasure.
Thank you.
Okay.
Thank you.
Thank you.
Thank you.
Hari.
Bye-bye.
Yeah.
Bye.
So I would we are concluding yet another interesting session and on adrenal disorder. I would like to thank our presenters, Dr. Jyotsna and Chiranta, for the wonderful cases, as well as their mentors, Dr. Divya Lakshmi and Dr. Riaz, for their efforts. And I would like to thank our expert speaker, Dr. Sri Nagesh from Hyderabad and Professor Nordenstrom from Sweden. And I thank all the attendees also for taking out time on Saturday evening and joining in. I would like to thank also the technical support we are getting from Nishad from RX events. And I would like to hand over to Dr. Shaila for her final remarks.
Thank you very much. Thank you. I think it was an excellent program. Thank you very much. Bye.
Thank
Good
you.
night.
The next
Thank you.
meet will
See
be
you
on
all again.
Sunday, May 29th. So yeah, I mean, kindly block your dates. Thank you.
Yeah, we will be shifting it to Sunday. Yes.
Sunday
Thank you.
29th. Yeah. Thank you.
Thank you.
all may
Thank
live
you.
well.
Bye. Good night.